Hello, welcome. Welcome to this webinar today on public health tools and resources for AHPs. I'm Kana Ahmed. I'm a dietitian by background and an AHP public health clinical advisor at the Office for Health Improvement at Disparities, which is based in the Department of Health. This is the second of a two-part webinar series on public health, and you can find recordings of part 1 and part 2 on the Future NHS platform. Our speakers today will be covering a wide range of tools and resources that are available to support you, AHPs, to take a public health approach in your day-to-day work. We'll be hearing from Professor Jamie Waterall, the Deputy Chief Nurse at OHID, Rachel Middle, an AHP Quality Improvement Advisor at OHID, Julie Lowe, a Senior Manager in Personalised Care and Social Prescribing at the Personalised Care Group, Linda Hindle, the Deputy Chief Allied Health Professions Officer for England at OHID, and Ben Whitaker, the Chief Sustainability Officer's Clinical Fellow at NHS E&I. Please post any of your questions in the Q&A today for our speakers, and we'll try to get to these after the presentations. And handing over to Jamie.
Hi, I don't know if colleagues can hear me. Oh, excellent, great. I could just see it was still live on Canal. So listen, colleagues, thank you so much for the invitation to come and speak to you this afternoon. Just before I go on to my slides, I wanted to first reflect and thank colleagues for all what you've done over the last few years. What a difficult and tricky time we've been living through, whether that's professionally, personally, and I still think it's important that we take time and thank colleagues for all the amazing leadership, and allied health professional colleagues are absolutely centre stage to the response that we've seen to COVID, but now importantly to a time and a decade that really is going to require us to think differently about how we approach health and care, and start to think more about public health and population health. And actually I think the timing's really right and important, because I think out of adversity and out of difficult times grows the opportunity to think about doing things differently and thinking about kind of what we've learned over the last few years. And so what I intend to do in my time is just reflect on some of that learning. In particular, I want to look at some of the latest data that's come out of from the pandemic, but also out of some of the latest data we're seeing out of the health profile for England data. So that's what we'll focus in on. So let's start with looking at the age standardized mortality rates for the population. This is looking at premature mortality, those under the age of 75, and you will see that from the data here, we have seen increased mortality in under 75 year age over the last year. So it increased from 2019 to 2020. But shockingly, in this data, we see that there is a significant difference between those living in the most deprived decile compared to those in the most affluent. In fact, it's 3.2 times the rate in the least deprived. So we knew prior to going into the pandemic that we had issues around premature mortality, but this starkly demonstrates and shows us that if we look at this by decile, this significantly increases. If we move on to the next slide. So this is looking quickly at our life expectancy data, and we know that there's been a gradual slowdown in life expectancy over recent years. Certainly over the last 10 years, we've been seeing a slowdown. But again, if we look at this by deprivation decile, for men, there's a 10.3 year gap in that life expectancy between the least and the most deprived deciles, and an 8.3 year gap for women. Just quickly move through the other slides. Just wanted to touch on why this was important. And it's obviously not only about life expectancy, it's about healthy life expectancy. And again, we see a similar picture here when we look at decile of deprivation, that there's a gradient for those living in the most deprived decile will live much fewer years in healthy life expectancy compared to those in the most or the least deprived decile. We move on. And just a couple more slides to kind of set the case for why we need to make a difference. This is looking at disease areas. So if we look at, and this is a common finding again against many disease areas, that we have a gradient on the decile of deprivation. So those living in the most affluent and least affluent communities are more likely to experience disease, depending on where they live. And again, this is quite a shocking finding, and something, you know, we really as health and care professionals need to question and challenge what we do to address this. Quickly move on, and I wanted to show. So obviously it's not all about disease areas as well. We really do need to be thinking about some of the major risk factors that are driving this disease, and particularly we look at the prevalence of obesity in children. This is age 4 to 5 at reception age. Again, we're seeing a similar gradient with more obesity in our more deprived communities. And if we move on one more time. And this is looking at education. So if we look at educational attainment or achievement, again, we're seeing a similar picture with this gradient, with our most deprived areas not achieving to that same level of those in the most affluent. So a real challenge for us. If we keep moving on very quickly, and we just move through this, thought colleagues be interested in looking at the global burden of disease data, looking at what are then the top causes of death in our country, and this is looking at the difference between 2009 and 19, seeing that we have an increase in certain diseases and some kind of falling down the ranking here, but ischemic heart disease, stroke, respiratory disease, low respiratory tract infections, lung cancer are kind of in the top causes. And then if we move on, I think we end up looking here quickly at disability adjusted life years, so combining premature death and disability. If we move on, this shows you the GBD data, where we're looking at that combined morbidity and mortality. Often colleagues don't always assume that musculoskeletal kind of conditions are one of the biggest causes of those disability adjusted life years lost, when we compare or consider those disease areas. Right, I think I'm almost done at the slides for kind of why it matters. This is looking at those DALYs again by risk. So the risk factors, if we think about the metabolic risk, the environmental, occupational risk and behavioural risks, these are the big risk factors that are causing that loss of disability adjusted life years. Finally, can we just move on? So it's just making the point that in the pandemic, we have learned that actually what we saw in the picture before with this real issue around the inequalities that we're observing in society, we've seen them playing out in the pandemic too. And so this is just a quick look at some of the data for confirmed case rates, cumulative admissions and mortality rates. And again, we've seen those in the more deprived population bearing the brunt of COVID more than those in the in more advantaged communities. Right, if we move forward, one more slide. This is vaccine uptake. We'll share these slides after. We'll move on to the next one. Right, okay, so how do we then, based on this clear need for change and reform, consider how we improve our approach to public health? And for a number of years now, we've been working on a programme called All Our Health, which tries to bring together the interventions we need to be deploying, whether that's at population level, community level or individual level across our places. And if we consider the impact that as a workforce, 2 million health and care professionals working across our system, we can make a significant difference and change to people's lives, whether that's through work we might be doing if we're in more public health roles, kind of considering policy or population interventions, or it might be those roles that we play in communities and thinking about how we affect and change services or our place at a community level, or it might be in our individual interventions that we're delivering in clinical practice on a one-to-one basis. If we just move through. And what we learned when we were developing this programme is there were clear barriers or challenges that as health and care professionals we were regularly coming across that was making it difficult for us to do this, around kind of having some of those difficult conversations, around our lack of confidence often in these topic areas, and particularly our knowledge related to some of these really important pressing public health issues. Colleagues were describing not always necessarily having the right level and the confidence and the knowledge to take action. So this clearly created a case for us to bring together in one easy, accessible place knowledge, data, evidence around the actions that we can be taking as health and care professionals on some of these big issues. So if we move on to the next slide. So over the last few years, working with topic experts across a really broad range of public health issues, we've come together creating over 30 resources on really important public health issues. So, you know, that could range from anything on childhood obesity all the way through to a brand new resource that's literally just gone live, and we're really pleased to be able to share with you as colleagues this first hand, because it's literally just gone live today, is a new resource that we've published on climate change. So there's a real broad spectrum of resources here, falling from those that we might consider under the arena of health improvement, health protection, kind of healthcare public health, life course, place-based services, supporting health and wellbeing and independence, and the wider determinants. And arguably all these things matter, they're all important, but it's for professional colleagues to choose the things that they want to home in on. If we move on to the next slide. So there's different ways you can access this content. You can either access it on the .gov website, and the links are in the slides. We'll be able to share these with colleagues, and the .gov website provides a flat version of the content, so you can just scroll down screen and you'll see all of the information kind of in one place. However, we also learned in some of the insights work that colleagues wanted it to be available in an e-learning format. So what we've also been doing over the last couple of years is working with the e-learning for healthcare team to create all of this content into interactive e-learning products. So you can access it via both sites. It's the same information, but one is just plain flat content, the other is kind of in an interactive format. And if you have an account with e-learning for healthcare, obviously it can track and collate all of the learning that you're doing. You can use this for your professional development, your revalidation, or just as part of your continuing learning and professional development within your role. We move on to the next page. So particularly within the e-learning products, each resource takes a view in four dimensions. So we firstly look at why does this matter? So for example, the latest climate change resource that we've published today will give you, within a very brief overview, the idea is that these should take no longer than 20 to 30 minutes to complete maximum, but you may just dip into the things that you want to look at. So you can go into the section to the top left, which says, why does it matter? Or you can go directly to the bottom left about what can I do to help? And most people actually, if there's anything they really want to get into, is the what can I do? What are the things, what are the evidence-based interventions, programs, policies that I can focus in on? So but then there's also where can I go for more? So where is there more data, information, guidance? It might be about NICE guidance, it might be about more learning resources and tools. Where can I go and get more? And then there's a brief knowledge check to the bottom right here. So all of the resources have these four segments that you can work through in order, or you can just go into the things that you're interested in. If we just move on to the next slide. The other more recent development that we have been testing is how you also look at these issues by place. So we've developed these interactive townscapes where you can go into a particular public health issue, for example, childhood obesity, and look across your place and think, right, okay, so if I'm interacting or working in a school environment, what are the things, what are the policies, what are the interventions, what are the programs we should be deploying in schools? If I'm working in local government, where can I go? So there's lots of different kind of resources and tools that you can use on the platform, and this is one of the new ones that we're testing. And then finally, last 2 slides. So obviously it's great because we're already seeing lots of people using these resources. We've had over 1.6 million launches of the content since they've been launched, but we clearly need to go much further and get lots more people using these resources. So if we move on to the next slide, what can you do to get involved? So we're asking for colleagues to become champions and to help promote this content, and we partnered with Carrot Learning, who will be able to help you if you want to become one of our All Our Health champions. Take a very short course and then be able to be a visible champion and leader for All Our Health. And again, we'll provide the links for this. And then finally, it's just about sharing the content and across your networks. If you're in a practice development lead, how can you share this with your colleagues? And I think, coming back to where we started, I think in times of adversity is a real opportunity to think about change and improvement. And if we really did kind of shift the dial on our health and care workforce, and arguably not only our health and care workforce, but beyond and into the wider public health workforce, across our blue light services and those in local government, taking greater depth and action on public health issues, we could make a real difference. Thank you very much. So that ends my presentation. I think I'm handing over to Rachel next. So over to Rachel. Thank you.
Thank you. So if you've heard that presentation and you're maybe feeling inspired to think about how your service could do something differently, then this presentation is about the Embedding Public Health into Clinical Services toolkit, which was developed in partnership with AHPs Health Education England and is hosted by e-Learning for Health. And that is a toolkit which you can use to help you actually go away and try and think about what your service is doing currently in terms of public health and prevention and what you could be doing more of in this area. So the purpose of the toolkit is to support everybody, service managers, team leads and clinicians across the health and care system to understand the case for prevention. So some of that, all our health resources are linked into the toolkit as well. Understand some of the terminology around public health, create the conditions needed for improvement, and then crucially use quality improvement methodology to guide your improvement project or whole service redesign. So this toolkit can be used to do larger service redesign pieces of work, but also smaller quality improvement projects. Next slide, please. Also, the toolkit is there to think about what you're already doing. So a lot of us already do prevention focused work, but maybe don't always recognise it or could improve the way we measure the impact of this work and how we share this with other people. It's also about looking for quick wins. So thinking about what small things that you could do that could possibly make an impact. So it's not always about doing big pieces of improvement work. We can do small things which can be more preventative in the way that we work. So in terms of the actual toolkit, the first 2 sections of the toolkit are focused on initially understanding the case for prevention. So that's covering lots of those things that were talked about in the previous presentation. So understanding the policy context, how this approach links to the aims of the NHS long-term plan, as I said, the All Our Health resources, and also some definitions and understanding around terms such as public health and population health and what we mean by those. The second part is around how you create the conditions for improvement. So with any change, with any new way of working, there needs to be the right culture in order for that to happen. So the creating conditions for improvement section talks about the importance of things like compassionate and inclusive leadership, how you create psychological safety in your team, and there's some kind of supporting resources which will help you do that as part of that section. Next slide, please. So the main part of the toolkit, the kind of section that focuses a lot on quality improvement methodology, is the 5-step process which guides you through a quality improvement prevention focused project. So there are 5 steps, and each of those steps talks about a case study. Sorry, move to the next slide. I think it's on the next slide. So thank you. Yeah, so in each of those steps you have an example case study. So that's a physiotherapy example, resources, and they link to the quality service improvement redesign resources, which some of you might be familiar with. So that's the quality improvement methodology side of things. And in each section there is also a reflection part, which gives you kind of example questions that you could use as a team to help guide your discussions in each of these areas. Next slide, please. So the first step is to understand your potential. So what are your local public health and prevention priorities, or what are the public health issues, needs, priorities of the kind of clinical population that you're working with, and where can your team have the biggest impact? So what are your skills and how can you influence those areas? Where can you add most value? So that first section links to resources to help you find what your local public health and prevention priorities are, and also understand where the resources are to help you think about where you can add value in terms of public health and prevention. Next slide, please. So the second step is all about creating your prevention vision for your service, and that having a clear vision is really important because it helps you build buy-in to your idea, helps you as a team be focused and knowing that, you know, this is our unique selling point, this is our vision, this is what we want to be doing in terms of prevention in public health. And if you're clear on that yourselves, then it's much easier to kind of sell that to other people. So some of the quality service improvement redesign resources in that section include things like how to use the driver diagrams, how to create a good vision, and also things like the 6 thinking hats. Next slide, please. So kind of happening at the same time as step 2 is step 3, which is all about engaging stakeholders. So knowing those people that are going to be affected by your proposed change, by you taking more of a prevention focused approach to your service, and also knowing who those people are that can help you get there. And if you're very clear with identifying who your stakeholders are and you know how you're going to engage with them, it's much more likely that your new way of working is going to be successful and you're going to achieve your desired impact. So this section includes resources about helping you as a team to think about who your stakeholders are, how you might engage with them, and how you might kind of work together to produce your elevator pitch, so you can really clearly articulate what your vision is for this project. And a key part of that would also be that co-production side of things with the people that use your services. Next slide, please. Step 4 is the fun part. That's about thinking, okay, we know where we want to be, but how are we going to get there? What are our change ideas? What are the ways that we could reach out, be more proactive in our service, try and address some of these public health priorities? So that's about generating your change ideas, prioritising them, knowing about how you're going to go away and test some of these ideas and evaluate them. And a crucial part of that is about knowing your baseline data. So if you're going to maybe do a piece of work to improve the way screening is carried out, so you're going to make sure that conditions or risk factors are picked up at an earlier point, it's about making sure how you're going to measure the impact of your training that you're going to do around screening. So is that thinking about members of staff's knowledge and confidence levels? Are you going to also look at if you're getting earlier, more appropriate referrals into your service? Does it mean that there's going to be less hospital admissions related to that particular condition? So being really clear on your initial data is really important, so that when you come to the end of the project, you're able to demonstrate impact. And in terms of testing and evaluating some of your change ideas, this section contains resources such as information on using PDSA cycles, and you might also want to use things like process mapping as part of this section. Next slide, please. Okay, so once you have gone and tested some of your ideas, you've had a go at working slightly differently, the last step is to really make sure that you've evaluated your project, you've shared it with others, you've had to think about if there's other ways that this work, other areas that this kind of similar work could be applied to, and you've thought about how you, if the project's been successful, how you're going to try and sustain it as well. Next slide, please. Thank you. So for new for this year, as part of the toolkit, based on feedback we've had from people that have used it already, we've added 5 new AHP case studies to the last section of the toolkit. And these case studies demonstrate how the toolkit can be used in practice to support teams to develop a prevention-focused quality improvement project. And all of those case studies also make it clear how they link to the greener AHP sustainability agenda, because being more preventative, taking that more public health approach is also important from a sustainability greener AHP perspective as well. Next slide, please. So in summary, the Embedding Public Health into Clinical Services Toolkit is designed to be as accessible as possible. So it's on e-learning for health. You don't need a login to access it. You can click in and out of it as much as you need to. We've also now got a downloadable workbook version of the toolkit, so you can make notes as you're working through it. You can print it off if that's kind of your preferred way of working. We've also developed a workshop session video for teams to use to talk you through the different parts of the toolkit and help you use it in an interactive way. So you can contact us for that video and plan if you'd like to use it. And we'd really like to hear your feedback on the toolkit, and if you do use it and you do use it to help you guide your project, we would also really encourage people to think about writing up a case study to go on to the RSPH AHP Hub. Thank you. So I'll pass over to Julie Lowe now to talk about social prescribing.
Great, thanks. I can see that the live, oh, there we go. Okay, fantastic. So hi everyone, my name's Julie and I work as the policy lead for social prescribing at NHS England and Improvement. So we're part of the personalised care group and we're working to embed personalised care across the NHS. Can I have the next slide, please? So social prescribing is an approach that connects people to community activities, groups and services to meet their social, emotional and practical needs that affect their health and well-being. And we know that as much as 90% of people's health is determined by other factors than the healthcare that they receive, so economic and environmental factors like how much money people have, or the housing that they live in, or the relationships that they have with other people. And people often seek support from health services with symptoms that arise from those factors. And whilst we can often treat the symptoms as AHPs or other healthcare professionals, social prescribing is more about treating the cause of those symptoms. So working with people to address their social determinants of health through social prescribing will improve their health and well-being. Next slide, please. So social prescribing isn't really a new concept. It's been delivered really successfully through the voluntary community and social enterprise sector for years, and it often comes under some other names as well. So we hear people talking about community connecting or community referrals. And there are lots of examples of social prescribing that happens in the NHS already. So where we as AHPs might support people to access benefits or welfare advice as part of our interaction with them, or we might connect them to community groups to reduce their social isolation and loneliness. But what we do have now in the NHS is a new workforce of social prescribing link workers, and these people have a specific remit to support people with their health and well-being through connecting them with community assets and providing non-medical support. And this doesn't mean that other professions can't or shouldn't do social prescribing, because actually if all of us in the health and care workforce supported people through this type of approach, then people can receive the right support in the right place at the right time for them and reduce the potential for their treatment to become over-medicalised. And from evidence as well, we think that if all of the workforce supported people to connect with their community, it might improve those people's ability to engage with health services in response. So if someone's supported with their finances, then they might have more money to get a taxi to their healthcare appointment, and then they don't miss their appointment, and so on. And we also know that social prescribing works particularly well for people who have one or more long-term conditions, who need support with their mental health, and people who are lonely and isolated. And those are all populations that we as AHPs might come into contact with across the life course at various points. So there's a real opportunity really for AHPs to step into this space. And we're already on the next slide, which is perfect. To support AHPs to incorporate social prescribing in their interactions with patients, PHE and the RSPH have produced a framework for social prescribing. So the framework has 4 sections that I'll talk through briefly, but there is much more detail available on the framework website, which you can see linked to on the slides, including some examples of practice. So I'd really recommend that people take that away from this session and have a look at that framework. So the first step on that framework is active signposting. So this is quite a light touch approach where AHPs will signpost people to local services. And this really works best for people who are confident and skilled enough to find their own way to a service after a brief conversation. And this is what we typically do as AHPs. So when we talk to people and we become aware that they have wider needs affecting their health, and we might signpost them to a source of support in the community. And the second step on the framework is around referring to those link workers that I mentioned earlier. So this is really for people who might need more support than active signposting, and it might be appropriate to refer them to those non-medical social prescribing link workers who can give them, time and space to talk about all of the factors that affect their health and well-being, rather than being limited to things that you know about in your role as an AHP. And they might be able to offer people a lot more time than you could as well. So working with people over, 6 to 12 contacts, they can work with people in their home or maybe via telephone if that's their preference. So it's much more flexible than maybe some of the services that we might be able to provide to people. We can also act as social prescribers. So this might be more appropriate for AHPs who are already providing long-term intensive support to people as part of your job. It might be appropriate for you to support people if they have quite a complex situation that might be outside the skill set of generalist link workers as well. So we often see in primary care, particularly occupational therapists working with link workers to provide that specialist expertise on the OT side of things, and then that link worker can support with those wider needs that don't need that specialist support. And then the last element of the framework is about AHPs acting as enablers to promote, grow and develop social prescribing. And I think this is the area that's really exciting for us as AHPs, because there's just so much potential for us to shape the development of social prescribing. So we can provide things like community groups and services for link workers to refer into. We can share learning and raise awareness with our AHP colleagues about social prescribing, what it is and what it does for patients. We can provide guidance, advice, supervision to those link workers so that they have that specialist expertise, and that includes raising awareness of referral routes to AHP support when someone's needs go beyond a link worker's level of competence, again ensuring that people receive the right support at the right time for them. And the last thing that we can do is that we can work with link workers and local services to develop pathways and approaches to better meet the needs of clients. So again, we've got lots of examples in secondary care at the moment where people are waiting for elective care procedures, where actually we can work together to support people in a much more holistic way than we might have done in the past. So that's a very quick canter through the 4 elements of the framework there, but I would really recommend that people look at the link. Can I have the next slide, please? And just really quickly, there's a couple of things that you might want to follow up on as a result of this session. So if you need more information about social prescribing, then I'd really recommend that you start with the excellent All Our Health resources that Jamie mentioned earlier. And there's also a King's Fund guide to social prescribing and animation linked on this slide. There's also a couple of really great blogs about taking a coaching approach to conversations and how to find out what services are available locally for you, including community activities or link workers, so that you can really join up with what might be available for people locally. There's a social prescribing network that runs nationally, and there's also regional networks, and we've got some new evidence reviews from the National Academy of Social Prescribing about who accesses social prescribing at the moment and the outcomes that we're starting to see from it. And then the last one is just some recommendations for accounts to follow on Twitter. So there's a couple of things here about where you can find the latest news on social prescribing in and outside the NHS. So if you're interested in finding out more, you'd like to keep up with routine developments, I'd go and follow those accounts. And that is all from me, so I think I'm handing over to Linda.
Thank you, Julie. Hi, everyone. So I am going to talk to you about this toolkit, Everyday Interactions, which we developed several years ago to help AHPs and other healthcare professionals to measure the impact of their mainly kind of making every contact count type conversations. So if we can move on to the next slide, please, Trudy. So as I said, this was first published in 2017, and then we did a refreshed document in 2020. And I'm saying we, it was developed with AHPs, but also as nurses, midwives, dentists and pharmacists, and it's been published by the Royal Society for Public Health. So the reason we did this was because AHPs kept coming to me and saying, we're doing lots in relation to public health and prevention, and we want to be able to demonstrate the impact of this, both for ourselves, for our own kind of personal job satisfaction, but also to our commissioners, funders, senior leaders, to be able to kind of prove the impact of some of the work that we were doing. So we started to look at how was it possible to measure the impact without increasing the burden, because the whole point of making every contact count conversations is that they are a very brief intervention. So if you add a great burden of measurement, then that kind of defeats the object. So so we went through quite a few conversations actually to find a way of doing this, and ended up focusing on a logic model approach to recording and measuring the impact of these types of conversations. So if we move on to the next slide, please, Trudy, we have now logic model pathways, which I'll explain in a moment what they look like, for 11 public health priority areas, and these mirror some of the priorities that Jamie has talked about in the All Our Health framework. So adult and childhood obesity, alcohol, smoking, mental well-being, falls, dementia, early years health, including children's oral health, physical activity, sexual health. And then we've most recently added a more generic pathway because colleagues who'd used this this toolkit said it would be really nice if we could create one for kind of more bespoke pieces of work that they were working on. So moving on to the next slide, please. This, I'm not intending to go through this in detail, but what this does is shows you the way that these impact pathways are set out. So there's a list of things that you might be doing, and then how you could record that, how you might collate that up over a service or over a period of time, and what the ultimate impact of that intervention would be. So this is an example for mental well-being. So the types of things that you might do, and it's not suggesting that you need to do all of the things, but suggesting some of the things that you might do. So it could be that you might have a MEC type conversation to raise awareness. You might offer brief advice. You might do a self-assessment. You might signpost to relevant services, perhaps using social prescribing, as Julie's just mentioned. And then again, examples of how you might systematically record that. So you could be recording that an issue is being raised, or that you've offered brief advice, or that you've signposted to particular services. And then the idea is that you know, over a period of time, or over an entire service, or a whole AHP team, you might be able to collate how many of those conversations have happened, how many referrals you've made to different services, for example, so that ultimately that could be modelled up to look at what the overall impact would be. And what we were trying to do when we started this work was to align it to evidence that was emerging, particularly around smoking, alcohol, and weight management and physical activity, actually, where we're starting to be able to see what the impact of brief interventions are. So whilst you might not be able to see that impact yourself, you might be able to model it up. So for example, we know that for about every 20 brief interventions around smoking, you would impact on the actual smoking status of one individual. And so if you were having 2,000 brief interventions across a year for your service, then obviously you're talking about 20 people's smoking status having been changed, which is then very significant in terms of health impact. So moving on to the next slide, please. Just to finish off, just to say that if you are interested in this and you want to look a little bit more, on the Royal Society for Public Health website, there is a very short e-learning resource that takes you through how the pathways work and how you can use them. So I've popped the link to that on there, and also the link to the toolkits themselves. So very quick overview, but I would recommend you go and have a little nosy around that toolkit when you've got a minute. And so now I'm going to hand over to our final speaker, which is Ben Whitaker, to talk about the Green AHP Hub. Thank you.
Thank you, Linda. I'm one of the Chief Sustainability Officer's Clinical Fellows at Greener NHS, and I'm hosted by the CAPO team and working on Greener AHP projects, including further development of the Greener AHP Hub, which I'll talk about today. Next slide, please. First, I'm going to answer the question, what is sustainable healthcare? Well, it's being able to use resources to deliver healthcare today without compromising the ability of current or future generations. And what we want to do is deliver healthcare without doing harm. To do this, we need to meet social, economic and environmental agendas. And next button, please. Sustainable healthcare lies in the sweet spot in the middle of this Venn diagram, where we have the triple win of meeting all three of those agendas. Next slide, please. So the current climate emergency that we're facing globally is also a global health emergency, and to address this, in October 2020, the NHS became the world's first health service to commit to reaching net carbon zero. The two targets are for the NHS carbon footprint, which is the emissions that we control directly, to be net zero by 2040, and by 2045 we'll have net zero for our carbon footprint plus, which is for the emissions we can influence, which involves a lot of the supply chain for the carbon footprint plus. I'm pleased to say that we're currently on track with these targets, but it's a lot of work ahead of us. To give some context, the NHS has more than 1.3 million staff. We're one of the top 10 largest employers in the world and contribute about 5% of total UK carbon emissions, which is similar to the emissions of countries such as Denmark or Croatia. So we have a big responsibility to tackle this, but it's also an opportunity, and in addressing climate change, reducing emissions, then we'll also benefit from improved health as a result. Next slide, please. So 1 year on from the NHS commitment, allied health professionals became the first professional workforce to deliver their own net zero strategy with the Greener AHP Hub. And we have an opportunity to contribute to the big opportunity, huge opportunity, to contribute to Greener NHS and beyond to tackle climate change and improve health. And a lot of the work we're already doing is contributing to Greener NHS, but there's still much to be done. And the Hub will help AHPs find out what actions they can take. The themes on the Hub were developed from a survey of nearly 900 AHPs across all professions, and 5 themes came from this. Well, the first was really about the importance of understanding sustainability, and under this on the Hub there's a section building on what we're already doing, and what we're already doing is practicing sustainable models of care. Next slide, please. So the Sustainable Models of Care framework is being developed by Greener NHS, and it may come out under a different name, but that's what it's called currently. And a large part of this is rooted in public health and preventative healthcare approaches of keeping people healthy over the course of their life. When people are unwell and we do need interventions, then it's providing care at the right time, right place, which links in with the Getting It Right First Time agenda and making every contact count. And then if people do need acute or crisis interventions, then it's thinking about how we provide them in a sustainable way. Next slide, please. The other 4 themes on the Hub focus on specific areas that AHPs are well placed to lead on. The first of this is public health and prevention. When Francis Mortimer devised the 4 principles of sustainable clinical practice, then preventative healthcare was one of these, as was supported self-care, both of which are integral to what we as AHPs do. We just may not have been seeing them through a sustainability lens. The other 2 that Mortimer devised were how have lean pathways, lower carbon treatment alternatives, and addressing those is largely around working in a very unsustainable healthcare system, which we're currently doing. So thinking about the most sustainable form of healthcare is how do we reduce the need for people to access healthcare services across the board? How do we support people and communities to live healthier and happy lives. So when we're working with people, thinking in what way may we also help reduce their future care needs. The other three themes on the hub are about digital transformation, reducing the environmental impact of equipment and the resources we use, and food and nutrition. So please do have an explore of the hub and look at those. Next slide, please. And yeah, just going to touch on some of the many health co-benefits of a low carbon lifestyle. When about a decade ago, the Climate and Health Council summarised these co-benefits, public health co-benefits, as what's good for the climate is good for health. And when the Lancet published a series of papers on this, they launched them, describing them as a convenient truth. So as we address carbon reduction targets in the UK, then this could mean increased walking and cycling, leading to reductions in cardiovascular disease, depression, obesity, diabetes, dementia, improving air quality, cutting road deaths and injury. And as practitioners, we may already encourage people to travel more actively, do more walking and cycling, but we haven't necessarily been seeing this through a sustainable development lens. And there are also many benefits of engaging with natural environments as well. Next slide, please. And on the hub, there is a page for actions you can take at an individual, team, or as a service or systems level, and circled in red, this section highlights the networks that you can link in with. If you're feeling like you'd like to look at this and address this, but like to link in with other people, then there are some suggestions here about how to do this. So that's a quick overview. Thank you, and I'll hand back to Kenar.
Thank you so much. So we've had a few comments and things, but before that, just want to say thank you to all of our speakers today, and to Magortu, Trudy and Stephanie at NHS England for their support with these webinars as well. We've put the key resources from this webinar on the chat. I think we've got one more to add, which is the Greener AHP Hub. We had a question in the chat about the All Our Health Champions programme, and Jamie has responded to that with the link to the Champions programme for people who are interested. And also, can I come to you, Julie, because you've posted about another Champions programme as well, so it'd be good to hear from you about that.
Yeah, thanks, Kenar. So one of the things that I probably should have mentioned in my presentation was that NHS England and Improvement and the National Academy for Social Prescribing are currently running a Champions programme. So the Champions programme for social prescribing is open to all NHS colleagues, clinical or non-clinical, regardless of grade or location of work. And really the Champions programme is aimed at spreading the message of social prescribing across various different parts of the health and care system. Linking up with other people, sharing good practice. We'll be providing an online community of practice and network to connect with other people. So it's a really great opportunity for anybody who is in that space of community engagement, or might be doing social prescribing in their role, to kind of get some extra recognition for that. So I've put the link in the chat where you can find out more information. There's also a role description and a link to apply. And I'm also very happy to take questions via email. We've got a standard email that's on that link as well. So yeah, just would be really great to see lots of allied health professional colleagues apply to that and then be part of that programme. Thanks, Kenar. Thanks,
Julie. Can I just check it's open to any AHP working in both acute or community, or?
Yep, absolutely. So any role, any band, any setting, they just do have to be employed by the NHS.
Yeah, thank you so much. It's really helpful. And just opening up to any of our other speakers, did you have anything else to add to the discussions today? Not at the moment. We've got another comment from Gerard. Thanks for a very helpful presentation and link to resources. Have to go. Thank you so much for attending, and thank you all for making time to come along to this today. We don't seem to have any other questions, but please do have a look at the resources that we've posted, and as well as having this webinar recorded and added to the Futures platform, remember we have webinar 1 on the Futures platform as well, and we'll also be recording both webinars and posting them onto the Royal Society of Public Health website, where we have an AHP hub that has all of the kind of public health resources, including all of the ones that we discussed today, and links to all of those. So it's kind of a one-stop shop for all of your kind of public health training, tools, guidance, evidence that we publish, all of our health inequalities work. And in addition to that, Rachel earlier mentioned about if you're interested in writing a case study about work that you're doing that's related to public health, so whether it's health inequalities work or doing some prevention or making every contact count, we're really, really keen to hear from you and publish your case studies on that hub. So do head over to the hub. There are instructions for how to create and publish a case study with us, and examples from across the kind of 14 allied health professional groups as well. So you can kind of browse and have a look at those existing case studies to see what they are, and if you've got anything that you'd like to add as well. Thank you all so much today. It looks like we've finished 10 minutes early, which is quite unusual, maybe because I've hurried people along as chair, but thank you for coming, and have a good day.